Well, it's interesting. A lot of the things that I've implemented in this practice have been based on my prior experiences in an academic center. When I was a resident, the attendings would supervise us and the fellows, and we would oftentimes group patients into specialty clinics depending on their problem. And oftentimes, then we would present the cases to the attendings, and they would help give us feedback and sometimes come in and see the patients or review them with us. I've tried to emulate that same model, but in the private practice situation in order um, to improve the pass through for the patient so that they can be seen in an adequate amount of time, but also have detailed documentation at the same time so that our referring physicians have deeper knowledge of what we've discovered and found out. The that organization that makes it similar to the university centers requires, of course, the physician, and I'm the only physician in this practice, to be overseeing and teaching the clinicians. The advantage with my physician assistants and nurse practitioners who can do 90% of what I can do is that I'm constantly interacting with them, increasing their knowledge, sending them out to obtain other knowledge from other practices and other lectures and conferences that we send us all out to. And then we bring all that information back to our center to help implement best practices as the evolution of neurology continues. This particular model lends itself to greater face-to-face time with the patients, but even face-to-face time with me. Even though they may not see me at every single visit, the time they get with me, I'm not in front of a computer because my team is doing most of the documentation for me. So I get to focus on analysis, interpretation of studies, and accuracy of the history so that we really understand everything going on with the patients.